I'm from New Jersey, so it's like early morning here. Before I start my talk, I'll just let everyone know, like, I caught COVID and I have a really bad cough right now, so you will hear me coughing throughout my speech. Sorry for that.
So really sorry to hear.
My research, it focuses on primarily health communication, program development, evaluation, and I have experience in not only in academia but also in not-for-profit sectors. I've worked with like marginalized populations, marginalized at multiple levels. I work with sex workers, primarily commercial sex workers. But like today I'm going to talk about sex workers, people like who are not talked about. We generally tend to focus our research on female sex workers, commercial female sex workers. But what we don't talk about, there is not enough research on cisgender male and transgender sex workers. And they come, like, for instance, I work with sex workers in India. They comprise at least more than 15% of commercial sex workers in the country. And it's so interesting because most of the female sex workers, I'm saying most, not all, a significant section of them are brothel based, like they're attached to a red light area. Unfortunately, like for a lot of the male sex workers, they are not part of brothels, they're not part of red light districts, they're generally transient. They work from different areas. And this is primarily one of the reasons that they always kind of fly under the radar. And if you look at the global statistic, a significant majority of men who work as sex workers, they are under-researched. There is not much discourse about them. So we are talking about communities, resilience, communities who are under-researched, communities who are marginalized. So I decided to talk about a community that is marginalized at multiple levels. Sex workers are marginalized, but male and transgender sex workers, they are like, even the marginalization is almost like intersectional, because this marginalization is happening at so many different levels. There's not much research that are done on these sex workers. They receive very little services. And when I was working with them, I realized that they are being marginalized not only by themselves, the community discriminates against itself, and the female sex workers also heavily discriminate against the male sex workers. So it's so interesting because you always think like, okay, marginalized communities, they will always stand together because they are facing the same experiences. But if you look at real life, that is not how it works. People always tend to discriminate against a population that they perceive as somehow a minority, somehow weaker than themselves, and they are much more likely to discriminate. So before I talk about commercial sex workers, like, I just go a little bit on community health. So what is community health? If we look at community health, it's an important subsection of public health, and it includes initiatives that can help community members maintain and improve their health, prevent the spread of infectious diseases. Now, community health can contribute to better health and equity. So we need to focus on the participation of the community. If the community is not participating, then there's not much chance of like solving, addressing the health disparities. We also need to create a participatory space on behalf of the community, and the knowledge that is generated can dismantle the structures that ultimately perpetuate this kind of inequities. Also, I think we need more multidisciplinary community-based participatory research approaches, which can include the core ideas of intersectionality, like social inequality, relationality, complexity, power, social context, social justice, and we need to include them in health research programs. Now, I'm going to talk about transgender and male sex workers. Now, the term transgender can be used to denote a person whose sense of identity, gender, does not correspond with the sex that has been assigned at birth. But ultimately, transgender is an umbrella term, and it can include more terms such as transsexual, which refers to a person who physically transitions from male to female or vice versa. Now, gender binaries have traditionally in vogue, but in a lot of cases, there have been terms like third gender that have been used to refer to people who do not subscribe to rigid gender roles. For instance, in India, a lot of the transgender population would characterize them as third gender. It's very interesting because in India, it seems that at least 85% of the transgender population in India, they engage in sex work as a primary source of income. The STI HIV rates among them are like significantly high, much higher than female sex workers. And the National AIDS Control Organization of India notes that 7.3% of India's male and homosexual and transgender population, especially the ones who are engaging in commercial sex work, 7.3% of them, they have HIV. In comparison, like only 0.31% of the total adult population. And the male and transgender sex workers, they're much more likely to become victims of violence, and they are much more likely to suffer from the greater likelihood of adverse health outcomes. If you look at them, the stigma that they suffer from is almost like an intersection stigma. This is not only on account of their population, but of profession, sorry, not population, not only on account of their profession, but also a result of their sexual orientation, gender identity, and gender expression. So it's like stigmatization that is happening at multiple levels. So they are hyper marginalized groups, and they're also an invisible population. Now I'm going to talk about why they're invisible, what causes visibility, what causes invisibility. Now, we had very little research done on sexuality, health, and well-being of transgenders and male sex workers, and there's also a lot of lacking information. Like what are some of the factors that can cause them to behave in certain fashion, especially when it comes to sexual health, decision making, and ultimately these serve as a barrier for effective formulation of intervention programs. So I had done a study among male cisgender, homosexual, and transgender sex workers in a red light area in India. So interestingly, I was mostly working with the female sex workers, but I decided to do one of my grant funded projects with male sex workers. This was one of the most difficult things I've done. So this was a study that was funded by a grant, and I had tried to examine the sexual health belief, risk perception, decision-making behaviors of the transgender and the male sex workers. This was ultimately a pilot study for designing interventions that can cater more effectively to this population. And it was anticipated that the study would help to formulate future programmatic interventions that can cater more effectively to the health needs of the male and transgender commercial sex work population. They had extremely high rates of HIV/STI. If we could reduce that HIV/STI risk, we could do HIV/STI risk reduction, also increase positive health practices. So the methods that I've used for the study was primarily a semi-structured interview-led questionnaire. I had used a guideline, but I had actually encouraged my participants to talk freely, and sometimes they express their opinion even outside the realm of the questions that were being asked to them. And it's very interesting because I had an IRB research approval that was done from my institution, but I also got approval from the State Ministry of Health. But very importantly, I had to get approval from the Sex Workers Union in Kolkata, where that project was being done. So, like the scholars, we are in the US, we are in North America, we are in Europe, we always have an institution review board, a process where we get the approval. But thing is, what we don't think is what kind of an impression does that approval cause on the people that we are trying to work with in a different country. The IIB approval means nothing to the sex workers that we are working with. It's just a piece of paper to them. I had to get approval from the Sex Workers Union. There is a Sex Workers Union in Calcutta. It's one of the biggest red light districts. It is from the biggest red light districts, and the activity, like all the actions of sex workers are governed by the sex workers union. But it's interestingly, I'm going to talk about this. Sex workers union is mostly run by the female sex workers. There's very little representation of the male sex workers. But if you want to do research with sex workers, doesn't matter whether they're male or female, you need to get permission from the sex workers union. The IRB approval doesn't mean anything to them. It's just a piece of paper to them, and they are not going to look at that approval and like, okay, come and do research. That's not going to work. So they will look at your study, they will meet, they will decide whether they will let you work in their red light district, even in the non-brothel area. You have to get permission from them. So the interviews were conducted at the sex work sites at the red light district. One was in Calcutta. It's one of the biggest red light districts in Calcutta, and the other one was in the red light district in West Bengal, which is the state where Calcutta is related, located. Sorry, not related, located. And I also did research in other locations across the eastern India, in the West Bengal, primarily in one state. So the data was collected from different locations. All communication took place in Bengali, and the obtained interviews were transcribed and translated. And I interviewed a total of 38 respondents, and I also employed a research assistant to help with translating the data and transcribing the obtained data. The average age of the interviews was 29.2 years. They provided me names, but that was not actually their original names. So they use a lot of pseudonyms when they're working in this profession. And among the 38 interviewees, 9 did not in, identify as sex workers, though they said they were having like transactional sex with multiple partners. So I have mostly identified, I transcribed the findings and analyzed them. There were 4 themes that came out of it, and I'm going to discuss these 4 themes here. So one important thing is the sexual identity. The sexual identity among transgender and male sex workers. It's extremely fluid. It's not well defined at all. And a lot of them would not even classify themselves as like homosexual, though they would say that we are men who love men. And they, for 12 interviews, specifically categorized them as transgenders. 10 of them call themselves women, but then they also said like they were biologically men. And some of the respondents referred to them, the transgender respondents referred to them as the third genders. Now, interestingly, some of the interviews were also married with children, and they were also engaged in sexual relationships with their wives. Uh, Only 2 of the interviews said that they were biological hermaphrodites, and 6 said that surgically castrated themselves following the religious observation of castration that are performed by the Hijra community. The Hijra community, this transgender community in India, they're called the Hijras. Now it's very interesting because I found they use a lot of English terms to refer to subgroups of people, like third group transgender people. They would use terms like tops and bottoms. And one of the respondents, like tops are people like who are like men who are basically engaged in anally insertive sex, and they were called the tops, and the bottoms were the one who were like engaging in anally receptive sex. So one respondent noted, like all male sex workers are bottoms. We are like women. We don't have any power over our tops, that is our clients. And it's very interesting because most of the male sex workers, male clients, they seem to engage in sexual acts and role playing that were characterized by dominant masculinity, whereas the sex workers were assuming a more submissive or feminine performance or positioning. And there appeared to be a performative masculinity that was at work, because the most of the men, the sex workers in the transactional sex, they were acting as bottoms. And as I said, they don't have much power in the relationships, not relationships, transactional sexual relationships that they have with their clients. So risk awareness and condom compliance. the interviews, they knew of the life-threatening consequences of HIV, that if they get an STI, that it's going to affect them for the rest of their lives. But 21 of them said that they use condoms sporadically. It seems that a lot of their clients were insisting on condomless sex. And this is so interesting because the female sex workers had formed a union where they kind of regulated condom compliance. And it seemed that uh, at least among the red light area in Sunagachi, where I had like work, the condom compliance rate among female sex workers was almost 98%. So very successful with condom compliance, the females. Among the male and transgender, condom compliance was like very poor. Most of the clients did not want to use condoms. 21 interviews, they said like, yes, I use condoms, but then like on further questioning, only 5 said that they use condoms regularly to relation sexual encounters. 17 said they use condoms sporadically, and if they're long-term clients, they're much less likely to use condoms. If they're intimate partners, they're much less likely to use condoms. Some of these men were married. They did not use condoms with their wife. So there were several reasons why they did not use condoms. Very interestingly, a lot of these male sex workers did not have access to the condoms. The condoms were first given to the female sex workers. The distribution of condoms was managed by the female sex workers, the union. They gave the condoms to the females first. Whatever was remaining, like if there were excess, they were given to the male sex workers. So the male sex workers did not have an easy access to the condom in the first place. Now, there was also a question of breakage and slippage of condoms. There was almost no conceptualization of lubricants, that you cannot use oil-based lubricants for latex condoms. They did not know this at all. Most of them were using whatever lubricants they could get their hands on. This would include like regular lotions that they use they use on a daily basis. They would even use like cooking oils and things like that. So they had no concept that like oil-based lubricants could break down the latex, and they were not aware of water-based or silicone-based lubricants. They did not know about that at all. And for instance, like I have interviews from my participants, and they said that clients did not want to use condoms, and even if they wanted to use condoms, like say like the lubricants, they do not have access to water-based lubricants. They hardly had access to condoms in the first place, and they had very little information of water-based or silicone-based lubricants. And one of my participants says that we cannot ask our clients to use condoms. We listen to them. They don't listen to us. If they don't want it, we can't insist on condoms. And somebody else said, many of my clients would not agree to sex without condoms. What do you suggest I should do? I keep myself safe by insisting on condoms, or should I just like go hungry or earn a few hundred rupees by doing what a client wants? So another contextual barrier for safe sex. So we are looking at like community-based, how to create resilience, but then there are so many barriers to attaining health, and like among the sex workers, like stigmatization and violence was like one of the primary reasons why uh, safe sexual behavior was not attained. Now, criminalization of sex work is a prevalent phenomenon. Violence is also one of the primary contextual factors. 32 respondents noted that criminalization of the profession and stigmatization due to the sexual orientation, it kind of completely took away their power to negotiate, use condoms, negotiate, engage in safe sex. And stigmatization were constantly noted to be a factor that prevented not only like screening and testing, but also condom compliance. Pressure to forego condoms were high from not only clients, but also from intimate partners. And very interestingly, the participants said that if they have a diagnosis of HIV, they were much more likely to get stigmatized by their own community members, by their own friends and families, by their own colleagues. Even active ostracization. For instance, one of my participants said that they don't want to get screened and tested because it seems that everybody else would think that they have an STI. They said, like one of my participants said, that you don't want to be seen going to get tested or going to a clinic. Your friends might think that you're positive for STIs or even HIV, and that's disastrous for your social life. So stigmatization by own community members, lack of support, and this is so in stark contrast to commercial female sex workers who are operating in the same area, who are unionized, who back up each other. The females are backing up each other. And they have built a coalition network towards working towards eradicating the stigma, addressing the barriers towards attaining health.
Satarupa,
Yes.
you have a few more minutes.
Okay. Yes, this is my last but one slide.
What a perfect timing. Thank you.
And as I was saying, the screening and testing, there's like little screening and testing being done. Only 13 had undergone like screening and testing. Regular screening is very infrequent. And as I was saying, it's primarily the fear of being diagnosed with STIs or HIV and the stigma that is associated with getting an STI. One of my respondents said that they only screen within a safe zone. That is their neighborhood. They will not go out of the neighborhood to screen and do testing. So one of them said, like, I stopped testing once my neighborhood clinic shifted to a different place. I don't want to go to the new place because people will think that we carry HIV. I don't want strange people I don't know to think that I have HIV because I don't want to be attacked in an unfamiliar place. So there is this fear of being labeled as a person who has HIV, as a person who has STI, and a person who's somehow who's deviating from the whole social norm. He's a male, he's a man, he's still a sex worker catering to females. So ultimately there is this like lack of community platform and resulting voicelessness. So as I was saying, a lot of these sex workers, the male sex workers that I interviewed, they are transient. They are not attached to the brothels. They're not attached to the red light area. They comprise even less than 1% of the administrative body of the union that runs, that the coalition of female sex workers. The union runs elections, but the female sex workers are never part of the governing body. So most of them work from different places. As a result of which, there is not even a community. You cannot build up a community platform where there is not a palpable community, when the female sex workers actively prevented them from getting into the coalition, from running elections. And the interviewees also talked about the divisions, the lack of representation on the sex workers platform, and there was negligible community support. So, like, I'm just end here. The identities of the sex workers, they were fluid. They indulge in high-risk sexual behavior. They have a very high risk of infection from unprotected sex. Violence and stigmatization was rampant in that community. Most of them were transient, and there was very poor community support. And the findings of the study, I think it can help to reduce the gap. We're talking about community health, we're talking about resilience, how we can reduce the gap in sexual health belief, knowledge, behavior, and health outcomes, and how we can form a foundation for basing future studies. So ultimately, I am talking about a community that is hyper marginalized. We're talking about community-based health. This community is hyper marginalized. Stigmatization is happening at multiple levels, and how we can build resilience among this community. So that is my talk for today. Thank you so very much for letting me do this. And if you have any questions, I would be so happy to answer them.